Now that we're done with the skull, let's move on down the axial skeletal into the vertebral column. The vertebral column has a lot of different functions. First of all, it supports the skull and the whole trunk of the body, and it allows for their movement. It protects the spinal cord, and the discs between it are going to absorb the stress of walking, running, and lifting. They also provide attachments for the thoracic cage and all of the postural muscles. There are 33 different vertebrae with intervertebral discs of fibrocartilage between most of them. The adult vertebral column averages about 28 inches long, and the intervertebral discs count for about a quarter of that length. The intervertebral discs are highly compressible. That's how they have some shock-absorbing capacity. In fact, they're compressible enough that you're 1% shorter at the end of the day than you are at the beginning of the day. The way they compress is by squeezing a little bit of water out during the day. And then at night, when we're lying down, they absorb water and the compression is removed. Try it out. Measure yourself in the morning and measure yourself at night. The vertebral column is broken into 5 different vertebral groups. We have the cervical vertebrae up in the neck region, the thoracic vertebrae in the chest region. Most of these have ribs attached. And then we have lumbar vertebrae in the lower back region, and then fused coccygeal and sacral vertebrae. There are some variations in the number of lumbar and sacral vertebrae, because after all, they are just a number of different fused vertebrae. Now, when a baby's born, there's only one curvature in the spine. It's that classic fetal position curvature. It's a C-shaped curve, and this is known as the primary curvature. However, as we grow up, we adopt a secondary curvature. This secondary curvature develops as a baby begins to crawl. As it lifts its head, we start seeing the cervical curvature. And then as we walk upright, we start to see the lumbar curvature. So this S-shaped vertebral column has a cervical curvature or thoracic curvature, a lumbar curvature, and then again a sacral or pelvic curvature. The thoracic and pelvic curvatures are present at birth, and the cervical and lumbar curvatures show up as we begin to walk. There are some abnormal spinal curvatures, often as a result of disease, poor posture. Pregnancy can have its impacts, or congenital defects. Scoliosis is where we see deviation in the spine from left to right. It's the most common abnormal curvature. Usually we see the scoliosis in the thoracic region, and it's prevalent in adolescent girls. In scoliosis, we actually see that the vertebral arch and body don't develop properly on one side of the vertebrae, and that's what leads to the curvature. Kyphosis is the classic hunchback that we see in osteoporosis. It's where we see an exaggerated thoracic curvature or hump-ish back. And then lordosis or swayback is an exaggerated lumbar curvature. We see that often during pregnancy, but we also see that when there's imbalance in the core muscles. Like when people do a lot of abdominal crunches without doing corresponding lower back work to keep those muscles strong. It pulls tension on the spine and causes this lordosis. So each vertebra has the same general structure. It has a body and a vertebral foramen or hole through which the spinal cord goes. What surrounds the foramen is the vertebral arch. The vertebral arch is composed of 2 portions, the pedicle right here and the lamina, which is sort of the tent-like portion on each side. There are spinous processes extending from the apex of the arch. These are the bumps we feel down along our spine. and it extends usually posteriorly as well as a little bit downward. There are two transverse processes on either side of each vertebrae that extend laterally from the point where the pedicle and the lamina meet. So the pedicle again and the lamina, and transverse processes. Each vertebrae sits on the next vertebrae, and so there are articular processes that allow them to articulate with each other. We'll see on this side the superior articular processes or facets. They're called processes because they're extensions, and they're also called facets because they are an articular surface. They're covered with hyaline cartilage, so they slip around on each other pretty nicely. Between each vertebrae, we see one of these intervertebral discs. That allows the body to articulate with the body of the next vertebrae in line. We'll see when we stack up a load of vertebrae that there's an intervertebral foramen. Again, foramen, hole. This is the passageway for spinal nerves. The intervertebral foramen is composed of two regions. The inferior vertebral notch in the pedicle of the upper vertebrae, so here's the inferior vertebral notch, and then the superior vertebral notch of the subsequent vertebrae creates the other side of the intervertebral foramen. Now there are 23 different intervertebral discs. The first one is between cervical vertebrae 2 and cervical vertebrae 3. As we'll see shortly, there's no need for a disc between C1 and C2. The last disc is between L5 and the sacrum. Each disc is a pad that consists of a nucleus pulpus, which is an inner gelatinous mass, and an annulus fibrosus, which is an outer ring of fibrocartilage. And they allow the vertebrae to stack on each other and support the weight of the body. They act in absorbing shock. Let's look at that disc. Here's the disc. You see the nucleus pulposus, the soft part in the middle, and then this cartilaginous ring, the annulus fibrosus. When we have a herniated disc, the annulus fibrosus breaks and the nucleus pulposus will squish out from between the annulus fibrosus. And that puts pressure on the nerves that come out through these intervertebral foramina or on the spinal cord itself. So it's quite painful. So now let's take a little closer look into the cervical vertebrae. Although each of the vertebrae in the vertebral column have all the general characteristics we just looked at, each region has some specific differences. The first two cervical vertebrae are especially different. They're the atlas and the axis. They allow the head to both rotate and nod. Here we have the atlas, and below we have the axis, which has a little projection coming up out of it, which allows rotation of C1, the atlas. So let's look closely at the atlas. The atlas is named Atlas because it's like the god that held up the world. And so the atlas has these superior articular facets right here that articulate with the occipital condyles on the base of the skull. Remember those protuberances that are right on each side of the foramen magnum? And they sit, as is illustrated here, right in the superior articular facets. This allows the nodding motion in the skull. So as you nod your head back and forwards, the occipital condyles are smoothly interacting with the superior articular facets of the atlas. The atlas has no body, so it's a little bit different in that sense. There are also inferior articular facets on the bottom because the atlas has to interact with the next vertebrae in line, which is C2 or the axis. we'll see there are anterior and posterior arches. The anterior arch being on this side and the posterior arch being on this side. We'll also see an anterior tubercle right here, as well as two posterior tubercles on the atlas. So next down in the line is the axis, or C2. The axis allows for rotation of the head. So the combination of atlas axis allows nodding between the occipital condyles of the skull and the atlas, and the no action by interaction of the atlas and the axis. The axis has an axis on it, the dens or odontoid process. This is a prominent knob on the anterior superior side. The axis does have a small body. It certainly has superior articular facets that interact with the inferior articular facets of the atlas. We'll see a vertebral foramen where the spinal cord passes through. The joint between the atlas and the skull is called the atlanto-occipital joint. And the joint between the atlas and axis is called the atlanto-axial joint. You'll see back here that there's a transverse ligament that holds the axis in place around the dens. So again, you can get rotation of the head in the no direction through the interaction of the atlas on the axis, and a yes motion by the occipital condyles interaction with the superior articular facets of the atlas, like the god holding up the world. So below the atlas and axis are more typical cervical vertebrae. They're small and very light. They have a bifid spinous process from C2 through C6. This is a characteristic that we can tell cervical vertebrae apart from any other vertebrae, and that's something that you'll need to be able to do. They have a very small body because they're supporting less weight than, say, the lumbar vertebrae, and a very large vertebral foramen because the spinal cord is much larger as it's leaving the skull. There are transverse foramen in each of the transverse processes. This is another characteristic that's unique to cervical vertebrae. These transverse foramen provide passage and protection for the vertebral arteries that supply blood to the brain, as well as the vertebral veins that drain blood from the various neck structures. C7 has a vertebra prominence. It's a very long spinous process, and it's not bifid. This is the one that produces the prominent bump on the lower back of the neck. It's a very convenient landmark for counting the different vertebrae. Now, the thoracic vertebrae are still a little bit different. There are 12 of them, labeled T1 through T12. They correspond to the 12 pairs of ribs that attach to them. They have spinous processes that are pointed and angled sharply downwards. In general, the thoracic vertebrae have the longest spinous processes, and that's the way we can really set them apart from all the others, as well as the fact that the spinous process is angled much more sharply downwards than the others. They have a much larger body than the cervical vertebrae, but smaller still than the lumbar. We'll notice an additional feature on the thoracic vertebrae, which are the costal facets. There are transverse costal facets, or articular surfaces, on the transverse processes. And then we'll see an inferior costal facet very close to the intervertebral foramen. And we'll also see a superior costal facet. So the ribs sit right in between the inferior costal facet of one vertebrae and the superior costal facet of another, as well as pressing up on the transverse costal facet. The lumbar vertebrae, number 5, L1 through L5, they're characterized by a very thick, stout body. This is how we can tell a lumbar vertebrae from any other. They have a much shorter spinous process, and it's pretty square. The costal facets are no longer there because obviously there are no ribs to articulate with. We'll see that the superior articular processes face much more medially, and the inferior articular processes or facets will face more laterally. This allows the lumbar region to resist as much twisting as we might see possible in the thoracic region. As we move down into the sacrum, we see that it's a bony plate that forms the posterior wall of the pelvic cavity. So we'll also have the hip bones on either side of this. But this is the axial skeleton. In children, we see 5 separate sacral vertebrae. About the age of 16, they begin to fuse, and that fusion is complete by the age of 26. On the anterior surface, the sacrum is very smooth and concave. It has 4 transverse lines that indicate where the vertebrae have fused together. There are 4 pairs of large anterior sacral foramina. These are the anterior sacral foramina, and they allow the passage of the nerves and arteries into the pelvic organs. The sacral promontory is located on S1 and supports L5. So this is the sacral promontory. When we look from the posterior view, we'll see that the posterior surface is much more rough. It has a median sacral crest that forms from the fusion of the spinous processes when they were separate vertebrae. And then we'll see also lateral sacral crests. They're less prominent, and they're on either side, right here, on either side of the median sacral crest. There are posterior sacral foramina, which are 4 pairs of openings that allow spinal nerves to supply the gluteal region and the lower limbs. The sacral canal runs through the sacrum and ends at the sacral hiatus. The sacral hiatus is here. It's where there's a slight pause between these spinous processes. The sacral canal will contain all the spinal nerve roots. The auricular surface is part of the SI joint. So this is the piece that interacts with the hip, this auricular surface on either side. The sacroiliac joint, that's where the sacrum joins the hip bone or the iliac bone. We'll also see there are superior articular processes on S1. These articulate also with L5. The ala are a pair of rough wing-like extensions that are lateral to the superior articular processes. Here are the ala wings. Now we move all the way down into the coccyx. The coccyx usually consists of about 4 small vertebrae. Sometimes there are 5. They fuse into a single triangular bone between the ages of 20 and 30. There are 2 little horns or cornua on coccyx number 1. These serve as attachment points for the ligaments that bind the coccyx to the sacrum. The coccyx can be fractured during a difficult childbirth or by a hard fall on the buttocks. If you've ever tapped your tailbone, you know that it's exceptionally painful. The coccyx is there to provide attachment from the muscles of the pelvic floor, which we'll explore in future chapters. So spend a moment here and diagram a standard vertebrae, including all the different processes, the vertebral arches, and all the facets. And then note the distinctive features of each of the different regions of vertebrae. Certainly, spend a little time exploring atlas and axis and their relationship in creating the yes and no movements of the head. In addition, add the vertebral column as a section to your outline. Create a section that has just the general vertebrae and then special characteristics that we see in each of the different regional vertebrae. Go into Anatomy and Physiology Revealed and be sure that you familiarize yourself with each of the features mentioned in this lecture. So now let's finish up the axial skeleton by looking at the thoracic cage. The thoracic cage is going to consist of the thoracic vertebrae, the sternum, and the ribs. It forms a conical enclosure for the lungs and heart and provides attachment for the pectoral girdle and upper limbs. There's a broad base and a narrow apex. The respiratory muscles act to rhythmically expand the ribs and draw air into the lungs. The costal margin is the inferior border of the thoracic cage, formed by the downward arc of the ribs. And this whole cage will protect all the thoracic organs, as well as the spleen, most of the liver, and to some extent the kidneys, as they sit right in here. The sternum is the breastbone. It's a bony plate that's anterior to the heart. You can see it right here. It's divided into three regions: the manubrium, the body, and the xiphoid. The manubrium is the superior portion that we see right here. It has a suprasternal jugular notch at the top and clavicular notches on each side for the clavicles to join. And the first two ribs will attach to parts of the manubrium. The body, or the gladiolus, is the longest part of the sternum. On it, we'll see the sternal angle. So this is the body of the sternum. And right down here is the xiphoid, or the xiphoid process. The only feature really on the body is the angle. That's where it attaches to the manubrium, right here. Now the xiphoid process is the attachment for some of the abdominal muscles. It could easily be broken during CPR if it's performed improperly. That's why we measure a few fingers up from the xiphoid process. We'll find the xiphoid process, measure up, and then do chest compressions right about here on the thoracic cage. And usually, if the compressions are deep enough, the ribs are going to snap away from the sternum. If the xiphoid process is broken off, the danger is that it can stick into the liver and cause fatal hemorrhage in the liver. So there are 12 pairs of ribs. There's no difference in the number between the sexes. The ribs have several features that we need to look at. First of all, they have a head, a neck, an angle, and then the shaft as it comes around the front. The head is the portion that attaches to the vertebrae. The head has the two articular facets that would go into the articular facets of each thoracic vertebrae. They have a superior articular facet and an inferior articular facet. The superior articular facet of the rib will match up with the inferior articular facet of, say, the T6 vertebrae, and the superior articular facet will match up with the inferior articular facet of the rib. So the rib sits right between the two vertebrae. You'll also notice that on the tubercle, there's an articular facet that interacts with the transverse process. On the back side of the rib, you'll notice a costal groove. This is a site for muscle attachment. So let's take a closer look at the articulations of the ribs with the vertebrae. Here you can see two vertebral bodies. The ribs will sit right in between, articulating with the inferior costal facet of T5 and the superior costal facet of T6. The rib has its corresponding inferior articular facet that interacts with the superior costal facet on the vertebrae, and a superior articular facet of the rib that articulates with the inferior costal facet of the vertebrae. So you can see it's important to be specific with your naming. This would be specifically the inferior costal facet of the vertebrae, and then this side would be the superior articular facet of the rib. Now there are true, false, and floating ribs. True ribs have their own costal cartilage connecting them to the sternum. So these are true ribs. False ribs share a cartilaginous connection to the sternum. So those are these ribs here, ribs 8 through 12, where they're sharing a cartilaginous connection into the sternum. And then floating ribs, 11 and 12, articulate just with the body of the vertebrae. They don't have tubercles, so they don't attach to a transverse process, and they have no cartilaginous connection to the sternum. So that brings us to the end of our section on the vertebral column and thoracic cage. It's now time to move into the appendicular skeleton. Before you do that, go ahead and diagram the components of the rib cage, especially how the ribs articulate with the vertebrae.